Unmute. President sir, unmute karantu.
I'm audible now?
Yes.
Okay. Esteemed
Yes, sir.
ophthalmologists, good evening to you all. I heartily welcome you all to this EIZOC ORTS webinar 4. Previously, we have conducted 3 series on uveitis, and this is the webinar 4 of this series. Today, the topic is intermediate uveitis and parasite associated uveitis. The speaker is Dr. Rathinam. She is Chief Uvea Services and Principal PG Institute of Ophthalmology, Arvind Eye Hospital, Madurai. I extend warm welcome to her to this webinar. Along with her, I welcome our mentor, Dr. Ajit Babu Majhi, past President EIOS, Chief Coordinator, Professor VNR Subuddhi, then Chairman Scientific Committee EIZOC, Dr. Sabyasachi Patnaik, Coordinators, Dr. Ashok Nanda and Dr. Anurag Mishra. I also welcome our moderators, Dr. Manisha Agrawal, Dr. Sanghamitra Kanungo, all panelists, and also I welcome to all the discussants. Happy to note that we are having a very good speaker, Dr. Rathinam, and our panelists and discussants are taking parts from different parts of and different medical colleges of our Eastern India with zeal and enthusiasm. This is definitely very helpful to all, and in particular for residents. So friends, after welcoming you all again and giving lot of thanks to you all for your participations, I hand over to Dr. Sabyasachi Patnaik, over our Chairman Scientific Committee, EIZOC. Thanking you all. Long live EIZOC.
Thank you, sir. Thank you very much. I'm not coming with audio because of my poor network. And I welcome you all to this, our webinar series, ORTS, for the residents and the general practitioners. We are very fortunate to have Madam Rathinam with us. I know him since 2000, when I had been to Arvind to have a training on diabetic retinopathy. And at that time, I think leptospira uveitis was recently, that was discovered at that time by the Arvind people, and Dr. Rathinam Madam was the key person for that. So I welcome you, Madam. And with this brief introduction, I hand over, I request Professor VNR Subuddhi to start the program.
Thank you, sir. Thank you.
Thank you, President EIZOC, Chairman Scientific Committee EIZOC, and all the participants in this webinar and all the viewers. I once again welcome you all to this, our residence teaching series number 4. And today's topic is really very interesting topic, intermediate uveitis and parasite associated uveitis. Before that, we had already 3 parts, one by Dr. Somasilamurthy, uveitis, then we had post-uveitis by Dr. Vishali Gupta, and after span-uveitis by Dr. Jyotirmoy Biswas. And today is the 4th in the series, and today we are fortunate to get Dr. Rathinam SR, Madam. With a lot of difficulties, we could get her. So thank you, Madam, being with us.
Thank you, sir. Thank you so much.
Yes, as already been told, we are the coordinators, and of course, nothing goes without our mentor. Mentor is really mentoring the subject and knitting very well. The last 4 webinars is guiding us a lot. And of course, today's speaker is Dr. Rathinam Madam. So to say briefly about Rathinam Madam, she has given a very good biodata, but I have to concise a little bit due to lack of time. So as you know, she is currently the principal professor of ophthalmology and head of the Uveitis service, working at Arvind Eye Hospital and PG Institute of Ophthalmology, Madurai. She established Uveitis clinic at Arvind 30 years back after training under the great Professor Namparmal Swami. Her basic epidemiological and clinical research uncovered the cause, source, and persistence of 3 unknown infectious disease outbreaks, which include ocular leptospirosis, rheumatoid eye disease in children, and ocular West Nile virus infection. She's got a lot of publications, number of publications, including the book chapters, more than 151, and she received so many awards. I can enumerate there are 13. The total citations of these publications received are 3,263, and maximum citation received by the landmark paper on epidemiology, that is about 382. As on 20th July, she has got 30 book chapters, and she has contributed chapters for books published in India, UK, Germany, Korea, and the United States of America. She is also the co-editor for the Wills Eye Manual UV Atlas and authored a manual on ocular pharmacology. She has got a lot of research studies, and they are nationally about 9 and internationally about 7 studies going on. And she is also a reviewer for the several national and international journals, including our EIZOC. She is the PhD guide and examiner. So this brief, I welcome you, ma'am, to this webinar. So
Thank you, sir. Thank you.
thank you. And today's moderators, really another 2 great moderators, Dr. Manisha. I think everybody knows Dr. Manisha Agrawal. She is the Secretary of Veterinary Society of India and also Secretary of EBS Society of India. She now presently she is working at the Shrops Charity Hospital. She is the moderator for this today's program, along with our veteran Dr. Sangamitra Kanando from our place. She is the retina and vitreous retina and UVA consultant at Corvision Eye Hospital, Bhubaneswar. And of course, our panelists today include Dr. Sarmishta Behra from Himsar, Burla, Dr. Ruma Das from Silchar Medical College, and Sachla Bhai from MKC Medical College, Barampur, along with Dr. Tripti County. Again, she's from Shrops Eye Hospital, Charity Eye Hospital, and now presently she's working as a consultant at the BBI Foundation and Netrala, Kolkata. And of course, our discussions today include 6 postgraduate students from different institutions of our EIZOC states. They are Dr. Sambhiranjan Parida from Burla, Vimsar Burla, Dr. Pragati Tiwari from AIMS Patna, Dr. Pratibha Behra, MKC Medical College, Barampur, Dr. Priyamada Subudhi from SC Medical College, Cuttack, and Dr. Priya Lakshmi from Silchar Medical College, and with Dr. Madhurima Kumar from RIO, Calcutta. So these are our postgraduates today. They will be interacting with the panelists, the moderators, and with the speaker. And I welcome all to this webinar. And I want, before I finish my talk, I request our moderator, our mentor, Dr. Ajit Babu, say a few words before we proceed for the program. So Dr. Ajit Babu, just 2 lines only. You're muted. You're muted, sir. You're muted. Yes.
I want to say very much thanks to Dr. Ratnam because in spite of her busy schedule and lot of commitments, that's what I hear from Arvind, that she has a lot of commitments and very great teacher actually. So I want all the PGs of East Zone to get a best benefit of her experience. That's what I want. And I look forward for her great presentation.
Thank you, sir. Thank you so much. Thank you.
So, thank you, Dr. Ajit Babu. Now I think we'll start the session with a case presentation by one of our postgraduate students, Dr. Pratibha Behra. So, Dr. Pratibha.
Yes, sir.
Yes.
Good evening, sir.
Please share your case and discuss.
Sir, is my slide visible?
No. You have to come.
Hello.
It's not there.
Not there.
You're not shared yet.
Yes, sir.
Not yet.
Sir,
Sayed, can you help her?
Ma'am, do you have the option of screen share on the bottom of the screen?
Yes, sir.
I guess your internet is,
Screen.
yeah, now we can able to see this.
Yes.
Started.
Just
Yes,
a
it is
moment.
come.
Yes. So may I start?
Wait, it's coming.
Hello.
Once
It's low. It's been getting loaded, ma'am. Just wait for a while. Ma'am, your bandwidth is low. You please put it on the slideshow mode, ma'am. It is taking a little longer time. Please put it on the slideshow mode. Your slides are visible.
I
Yeah,
have
full
put it
screen.
in slideshow mode. Is it visible now?
Yes.
Yes.
Yes. Can I start? Hello.
Ma'am, your slides are not clearly visible. It's not on the slideshow mode yet. It is taking a longer time, maybe
Yes.
because of your bandwidth.
And I think you can proceed.
Now it
Is
is
it
all right.
visible
You can
now?
proceed with this. Yeah, yeah.
41-year female from Khordha, Odisha, presented to our OPD with chief complaints of diminution of vision and floaters, left eye more than right eye since 6 months. Then coming to the history of present illness, my patient was apparently all right 6 months back. To start with, she developed painless, progressive, gradual diminution of vision of the left eye, which is associated with floaters. No history of weight loss is present, but no history of loss of appetite present. No history of any scale, oral or genital reasons present. No history of any trauma present. No history of fever or evening rise of temperature present. No history of cough or expectoration is there. No history of any drug. She had taken some eye drops from a local store, but the symptoms did not subside and no documentary evidence is there. Coming to the past history, similar attack of 6 episodes, which was associated with pain and redness 3 years back in the left eye, and a single episode of similar attack on the right eye 2 years back, which she had taken eye drops from a local store. After that, she went to an eye hospital for gross diminution season, where she was treated with intravitreal triamcinolone acetonide injection in both eyes in 1 year back. History of intermittent episodes of asthma-like features present since 8 years, for which she was taking some medications, and no documents are available. No history of diabetes, hypertension, or TB, or any contact with TB patient present. No travel history present. Family history is nothing suggested. To the personal history, patient is a housewife, belongs to lower socioeconomic status. She is on mixed Indian diet with normal bladder bowel habit, but she is having disturbed night sleep. Coming to the general examination of no coming to the systemic examination, the systemic examinations are also within the normal limit. Coming to the examination, right eye visual acuity unaided, pinhole improving to 6/12, and near vision is N8 with the retinoscopy plus 2.75 diopter in both the medians, and the best visual acuity is up to 6.9 by giving plus 0.75 spherical lenses, and plus 1 spherical lenses is added for the near vision. And IOP by NCT is 17 mm of Hg in the right eye. LPI is pattern. Coming to the left eye, unaided visual acuity is CF 2 meters with pinhole not improving. Near vision is N36. Retinoscopy shows faint glow. The best corrected visual acuity is not improving with the glasses. And IOP by NCT is 13 mm of Hg and LPI is pattern. Coming to the anterior segment examination, in the right eye, the anterior segment examinations are within normal limit, whereas in the left eye, in the eyelid, mild edema is present, eyelashes are normal, conjunctiva is quiet. In the cornea, few fine capes present in the corneal endothelium. Aqueous flare is 2+. Depth is irregular due to the synecdoche. Iris color pattern is normal. No iris nodules present. Pupil is irregular due to the posterior synecdoche at 3 o'clock position and sluggishly reacting to light. The lens is NS2 with central PSC. Few pigment dispersion is present over the anterior lens capsule. This is the anterior segment of right eye. And this is the anterior segment of the left eye. So in few KPs and flare is 2+. Coming to the posterior segment examination by indirect ophthalmoscopy, the ocular media is in the right eye. It has grade 1 vitritis, optic disc size normal, color pink, margin well defined, coverage ratio 0.3:1, vessels 2:3, AV ratio, macula FR present, peripheral fundus within normal limit. Whereas in the left eye, the vitreous size is grade 2 vitritis, size normal, color pink, margin well defined, cubic ratio 0.3:1, vessels 2:3, macula FR is absent. Peripherally, we can see snowballs and snow banking, which is present inferiorly. This is the posterior segment of right eye and the left eye. In right eye, we can clearly see the disc, and whereas in the left eye, this haziness vitritis. In the B scan picture of the right eye shows a few vitreous opacities, whereas in the left eye, the exudates coalesce to form a exudate membrane-like structure, and the spikes are 10 to 20% of the full spike. This is the OCT picture. Upon is the OCT picture before triamcinolone and acetate injection. In the left eye, the central macular thickness was 57 micron, whereas after injection, the central macular thickness has become now 364 micron. This report the patient shows neutrophilic leukocytes. The ESR is 8 mm fall in first hour. Urine is within normal limit. Bantuk state is positive, which is 20 mm. CRP is positive. ASO positive. RF factor negative. Toxoplasma IgM negative. Hemoglobin is 12.8 gram per. RBS is 108 milligram per deciliter. ICT is negative. VDI.
So the speaker is disconnected, sir.
So I think her net connectivity is poor.
Yes.
Hello, ma'am. Hello.
Yeah.
Is it audible now?
You are
No,
audible. You are audible. You can. Slides are not visible, but you can present the rest of the case without slides if you want to.
So, from investigation, I will start. So,
Yeah.
Yeah.
hello.
Yeah, you can
Yeah.
start from investigation.
CBC shows, yes, sir. The CBC shows neutrophil leukocytosis. Montauk state is positive 20 mm. CRP is positive. ASO is positive. Urine is within normal limit. RA factor negative. Toxoplasma IgM IgG negative. Hemoglobin is within normal limit. RBS is 108 milligram per deciliter. ICTC negative. VDRL negative. And CECT thorax is normal. Serum ACE and serum calcium reports are pending. So my slides are visible?
Yeah.
Yes.
Hello?
Yes.
Yes,
Yes.
it is.
Yes.
Yes, sir. This is the CECT. This is the CECT of thorax, which shows no significant abnormality, and therefore my provisional diagnosis resolved intermediate right eye and intermediate uveitis complicated with cataract left eye. And treatment given is hydroxychloroquine acetate 1 drop 6 times per day for 1 week, which is to be tapered weekly. I drop homatropine 2%, 1 drop 3 times per day. I drop nepafenib 1 drop 3 times per day. I drop carboxymethylcellulose 1 or 3 times per day. And we have advised for the pulmonary consultation. Then after we have decided to start oral steroids. Thank you, sir.
Thank you for the nice presentation. It's a good case.
So thank you, Dr. Pratibha. That was a very nice case presentation. Apparently, we lost your voice in between. So I think we will take up a few very relevant questions which have come out of your case presentation. The first, I will briefly summarize the case for those who could not hear it properly, that you are dealing with an elderly female. She is a married female who had a mixed dietary habit, And 6 months back, she started having a problem. There was no relevant systemic history. And she had an evidence of anterior uveitis along with an element of posterior uveitis in the form of vitreous haze. And there were snowball opacities which were present in the left eye. Is that right? And apparently
Yes,
this patient underwent, there is a history of intravitreal triamcinolone injection, which was given in both the eyes 1 year back. And now you have started this patient on topical and on oral corticosteroids. The patient on investigations had Mantoux positive, which was very relevant. And other than that, I think there was nothing very significant except for a CRP also, which was positive. So now let us take up a few questions which are going to be of benefit to all the students, and they can feel free to ask. We have a very senior experienced uveitis specialist, Dr. Ratnam, sitting with us. So, ma'am, I would like to ask you that this patient apparently is a patient of intermediate uveitis. And how do you think this patient underwent investigations like toxoplasma was also checked, and so many battery of investigations were done? How would you approach this patient if this patient presented for the first time in your clinic?
Yeah, as you rightly mentioned, Manto 20 is very significant. And in intermediate uveitis, we all know TB, sarcoid stand first. Of course, idiopathic is a very big chunk where we cannot have any diagnosis, but we have to rule out tuberculosis and sarcoidosis. Occasionally, other diseases like cat scratch disease or Lyme's disease or leptospirosis, those things are very, very rare. So having MAN2 as 20, I will definitely ask for CT scan. CT scan, because X-ray chest is very less sensitive, and CT scan, and if possible, ultrasound abdomen also, because sometimes we may have mesenteric lymph nodes, para-aortic lymph nodes. If patient can afford, he can just ask for CT scan and CT abdomen, because it is not only pulmonary tuberculosis, other extra-pulmonary tuberculosis. And sometimes the same patient may give history of recurrent fits or severe headache, and we may have optic disc edema. In that case, instead of abdomen or in addition to abdomen, I also do CNS CT. So first thing is to rule out tuberculosis, because in these cases, we are going to start steroid, and if they do not respond, invariably we go for immunosuppressive. So before we go for immunosuppressive, infectious agent has to be checked. And of course, syphilis also, because both TB and syphilis can look like anything, any part, anterior, intermediate, posterior, or pan. So when we rule out all these infectious uveitis, and when I am sure that it is not infectious, I go for steroids followed by immunosuppressive.
So, ma'am, thank you for that answer. But I have one more question, which is pertaining to the investigations. Would a toxoplasmosis really have a presentation like this? Like you said, that we'll rule out tuberculosis, which can present like a bilateral vitritis. Would it be really relevant to do a toxoplasma in this?
Not at all. Not at all. Because specifically, ELISA serum toxoplasmosis is not at all relevant to the ocular picture. And usually the ocular picture, when it is either acquired toxoplasmosis like focal retinitis or with a healed scar, even the clinical diagnosis will tell us. And invariably, the serology sensitivity is only 12%. So even if you ask the patient to do IgG as well as IgM, many times it doesn't help us. And especially in this presentation with bilateral intermediate uveitis, I will not ask for toxo.
So I think what is relevant is that toxoplasma is primarily a clinical diagnosis.
Yes.
And it is going to be having a very classical picture, though very few cases can be an atypical presentation, but majority will have a very classical picture, like we typically read in the books as headlight and fog appearance, where you'll have a focal vitritis overlying a patch of retinochoroiditis. And you can have, a very classical presentation. So you really don't need to order toxoplasma investigation in each and every case, especially in this case which was presented.
Yes.
One more question which I think is very relevant is that here we are dealing with a bilateral etiology. So both the eyes are involved. Would anybody really opt for bilateral intravitreal injections, or would you opt for a systemic therapy which is going to be having an effect on both the eyes? Ratnam ma'am?
Yeah, definitely systemic therapy. Instead of giving both the injection, when we do not have a definitive diagnosis, it is always systemic therapy.
What is the vision, Pratibha?
6 by best corrected was 6/9 in the right eye and counting fingers in the left eye, improving probably to 6 counting fingers.
Yeah, when the
Yes, sir.
vision
In
is
the right
6/9 in one eye,
Yes, sir.
in intermediate uveitis. The other eye,
Yes,
anyhow,
sir.
definitely it requires intervention. But when vision
Yes,
is
sir.
not getting affected, certain times better not to go for any intravitreal injections
Yes.
or anything like
Of
that.
course,
Sir,
because that
the
is the only
patient
C.
has taken
Yeah.
intravitreal. Sir, the patient has taken intravitreal injection in other eye hospital 1 year back only.
It's okay. It's
We
okay.
have not given any intravitreal injection.
I'm not saying
Yes.
that.
Thank you,
In
sir.
intermediate uveitis, when the vision is good, certain times you may have to be more conservative in management. That's what I'm indicating.
Yeah, I agree with
Okay,
Dr.
thank
Babu.
you so much.
And can any of the PG students tell us that which is a very important overtreated clinical uveitis picture, which is often misdiagnosed as intermediate uveitis and treated with long term of oral steroids, a very typical entity which is overdiagnosed and overtreated. Can any of the PG students answer that? And how would you differentiate it from intermediate uveitis? Dr. Behra, would you like to take up that question? So I think Ratnam ma'am will agree with me that we have Fuchs heterochromic iridocyclitis, which is a very commonly misdiagnosed entity, not requiring oral steroids. You have a very typical young patient coming with vitreous floaters. But when you do the investigations, there will be no evidence of any disc leakage. There'll be no evidence of cystoid macular edema. But just by seeing those exudates in the inferior vitreous cavity, patients, doctors, they misdiagnose it as intermediate uveitis. And those patients are overtreated with oral steroids, landing up with complications like secondary glaucoma and cataract.
Yeah, I absolutely agree with you. Many times we have seen this.
So that is something to be kept in mind.
Yeah, absolutely.
Dr. Sangmitra, anything from your side?
So many a times we brand intermediate uveitis as idiopathic. So before branding intermediate, like it's a common consensus amongst all of us that intermediate uveitis is an idiopathic uveitis. So before branding it as idiopathic, probably looking at all the signs and symptoms, one should do the tests and not overdo the tests as seen over here, but do all those tests and then come to do not brand it as idiopathic, and I mean go on doing finding out the cause till you get a cause, and probably you can brand it as idiopathic and revisit your diagnosis every time the patient comes. Probably the next time there might be some other features where you can improve your diagnosis and then put it brand it as name it as a give it to a specific cause to the uveitis.
In this case, because the left eye is having very poor vision, maybe the media is very, very hazy. So we can do, because MANTO is also positive, if we do not get any clue from the CT scan, we can take vitreous core vitrectomy as a media clearance, as well as the vitreous can be subjected for PCR TB in centers where PCR TB is available. RT-PCR tuberculosis, not PCR, RT-PCR tuberculosis.
Madam, what about IGRA test? Do you advise IGRA?
No, even our government doesn't support IGRA. They say that both IGRA and MANTO, they do not correlate at all. So they give more importance to Manto only in our country. But people who can afford, of course, they can do. And provided the clinical situation goes along with TB, don't give too much importance to either IGRA or Manto, because we are not going to treat the immunological response of the patient. Rather, we are going to treat the infection of the patient. So usually I do only Manto.
And ma'am, do you prefer an ultrasound abdomen or a CT abdomen for ruling out abdominal TB?
If the patient is obese, definitely CT abdomen. If patient is not obese and cannot afford for 2 CTs, then CT chest and ultrasound abdomen. If they can afford, in one go, both CT chest and CT abdomen.
I will now request Dr. Subudhi to introduce Ratinam ma'am, and then we can just go ahead with ma'am's talk.
Thank you. I already introduced Dr. Ratina Madam to all the audience. I think she should start the talk. Yeah.
Thank you, sir. Thank you. Is my slides visible?
Yeah, ma'am. Yes, yes.
Okay, I am audible also. No?
Yeah.
Yes, clear.
Yeah, now we have 2 different topics. One is parasitic uveitis and another is intermediate uveitis. Because we have quite a lot of pictures in parasitic uveitis, I selected that as first choice. And it's not moving. Yeah, the parasitic uveitis will not be as obvious as we see in this picture. Many times we will be seeing this and we see the resident, we call the resident and we'll be excited to show this. By the time the resident looks into the slit lamp, this worm might have gone into the retrobulbar space. So it is highly motile and rarely we get to see such a clinical picture. It is very difficult to diagnose parasitic uveitis. And in fact, I would say that if any uveitis, for that matter, if it is not fitting with the typical picture of uveitis, we have to rule out masquerade syndrome as well as parasitic uveitis. And that is very, very important. I'll show you some of the pictures which will make you think that it may not be very, very typical always. Before that, we will go to MBBS class where our 3rd year teachers were talking about protozova and metasova, and protozova toxoplasmosis, but we are not going to cover in this because that is a separate subject by itself. In metasova, we have 3 things: nematode, cestode, and trematodes. Believe me, students, we have nematode infection in eye, cestode infection in eye, trematode infection in eye. Am I audible?
Yes, ma'am, you're audible.
Yeah, please continue, madam. Continue.
Okay. So for nematode, we will have 2 examples. One is Toxicera and Dusen. We have quite a lot. I'll be showing one by one. And in cestode, cysticercosis. That is it is a tinea solium. And trematode Procervum varium, which is recently diagnosed and recently identified disease. If you see ocular, nematode is otherwise called roundworms, cestodes called tapeworms, and trematodes are called flatworms. You will be interested to see some of the different type of nematodes in this presentation. So we are starting with roundworms or nematodes. In nematodes, you have Dusen, where you do not know the name of the worm, but you see the structural damage done by the worm. The second one is Dirophilariasis. I will show you a typical case. And Ganthostomiasis, Toxocariasis, Onchocerciasis, Loya. All those things are coming under nematodes. The problem with the diagnosis is we cannot do any blood test. we cannot do any serological test because the eye, a small structure, may have one small worm or larva, and that may not have any antibodies relevant to the eye in the blood or serum. So whatever you get positive may not be relevant to the eye at all. And painfully, we don't have enough medicines. In parasitology, we have very few medicines and we are not really sure whether they will be killing the worm or not. I have a patient who had pinworm infestation for years and decades till she died. So many times we have given whatever anti-parasitic agents are available and she never got better. And I have seen few more patients. I used to think there are some genetically weak patients always get this pinworm and they can never get rid of it. And literature, do they help us? Not at all. Because parasitic diseases are common only in developing poor countries, and developed country literature doesn't talk about parasitology at all. So literature doesn't help us. So we have great challenge in handling parasitic diseases. This is the best example of Dusen. You see the track marks, beautiful track marks. So under the retina, it has traveled a long way, and structural damage it has caused so much, but still we don't see a worm at all. Most probably this is the site where the alive worm will be there because active retinal lesion is seen here. But still we don't see the worm shape or anything like that because it is there in the subretinal space. If it is above the retina, we can see. If it is in the vitreous, we can see. We have few videos in Aravind how the alive worms dance. And somebody is not muted. Please mute.
Dr. Meher.
Yeah, okay. Thank you. And this is these are the structural changes. How do we treat this patient? We give albendazole for 14 days with steroids. Even though we are not seeing our enemy face to face, albendazole 14 days with steroids will definitely get rid of the worm. We need not go behind with lasers because laser will further harm the retina. And sometimes when we hit the worm with the laser, this worm will jump here. And we will be jumping with the laser here, then here, then here. So it is very, very difficult to kill with laser. Instead, you give albendazole and steroid and it will take care of everything. We have beautiful cases where these worms were killed only with anti-parasitic agent, and to prevent any allergic reaction or immunological reaction, we also give low-dose steroid for all these 15 days. And this is gandostomiasis. You see a very stout worm, very thick worm, and you can even see the lumen inside. And this robust thick worm is 1 to 5 millimeter. It's very, very, very small, 1 to 5 millimeter. And the thickness is invariably 600 μm. And this worm can cause again structural damage. It can penetrate the iris. It can damage the trabecular meshwork. It can get into the eye. It can do all sorts of harms. And we have to kill the worm. And sometimes it will go and hide in the angle of the eye. We have to see through the gonio lens. See, it is beautifully sleeping in the angle. So, and we need not go and do laser. You give albendazole and steroid, it will get killed on its own. And the second worm is Dirofilaria. Dirofilaria is very, very thin worm and long worm. It is 15 centimeter. See here, it is folded 3 times and still it is so long. And sometimes, and it is as thin as 150 micrometer, which is 1/4 of gandostomiasis. And you can see a thin worm like this. And males are smaller than females. And we have to also understand, as we grow, when we are children, we are very small. When we become adults, we are taller. Like that, these worms also have varying life stages. According to the stage, the size of the worm will vary. But definitely, gandostomiasis worm is thicker and this is very thin. And here also we need not to chase the worm with the needle. That will harm the patient's iris as well as lens. The moment we enter with the needle, it will go behind the iris. Invariably, they go behind the iris. We will not succeed. Instead, we can give albendazole and steroids. Onchocerciasis we don't see in India at all, only in Africa, and extensive chorioretinal scars and pale optic disc, and both they will be blind, and they will have corneal opacity as well. And the lower will be like this. And even Indian patients who have visited Africa 7 to 10 years back may harbor one worm, and when they come here after 7 to 10 years, they may develop lower nodules. So the past history has to be really important. But past history has to be elicited properly, whether they have gone to African countries or South American countries. And lower nodules may have the worms, and ivermectin should not be given for ectoparasitic conditions, because if lower is there, they may develop anaphylactic reactions. So we have to be careful that they don't have lower in addition. And now we are coming to, we have finished nematodes. So many worms we have seen: Dirophilariasis, Ganthostomiasis, Onchocerciasis, and lower. Now we are coming to chestod or tapeworms. This you know pretty well. I'll give you a beautiful case. A very young child, beautiful child, came with hypopion uveitis. Any of the students can give me differential diagnosis. A child with hypopion. Anybody want to give differential diagnosis? You forget that this is parasitic class.
Pragati, something else other than uveitis?
If there is trauma, history of trauma, so then endophthalmitis.
Wonderful. Anything else? A child with hypopion?
Yes. Child with pseudohypopion.
Retinoblastoma, yes. In fact, when I received this child, I was very, very sad because she was looking beautiful, only child of a very poor family. And I thought it is retinoblastoma. And what I did is, I dilated the pupil, and there was something floating like this. And there are so much of seeding. And now, do you think of retinoblastoma?
No, ma'am, not.
No, it is still possible. Retinoblastoma that has come to the vitreous, and all these seedling may be retinoblastoma seedling. Do you agree with me?
Yes, ma'am.
Yeah. So I almost thought it is only retinoblastoma. I wanted to do further investigation. So as you rightly mentioned, muscular syndrome was the first diagnosis. Second was endogenous endophthalmitis. We did ultrasound, and ultrasound gave the diagnosis. It was cysticercosis. One cyst intact subretinally, another cyst ruptured, and it has caused so much reaction. So a ruptured cysticercosis and with intact cyst. And this intact cyst is the one that gave the diagnosis. So we did vitrectomy and we removed all these debris, and we removed this cyst intact. But unfortunately, in spite of everything, the patient eye went for phthisis. Because we often hear that ruptured cysticercosis can cause severe reaction. It caused severe reaction, and then a patient was not seeing. So this is the way, and it was cysticercosis. Luckily, it is not retinoblastoma, but still the child lost her vision. In the extreme periphery, there was a hole in the retina. Through that hole, there is a cyst has come into the vitreous. So this is the one example of chestodes. And here we have to be extremely cautious, because this child may have other cysts in other areas, especially in the brain. So in order to see, we have to do neuroimaging also, about which we will see in the end of the class. Then comes the trematode. Trematode, many of you might not have seen. The students who live in Tirunelveli of Tamil Nadu, Kaveri riverbed of Tamil Nadu, and in some Karnataka areas and some Orissa packets, and students from Sri Lanka might have seen this trematode cases. All others might not have seen. This is called a fluke or flatworm infection. This is quite common in South India, Sri Lanka, Southeast Asia, Egypt, as well as in Brazil. So it is internationally, it is seen, especially along the equator. And you might have seen these snail-oriented worms in your Satterjee book in parasitology. Now we are showing, see, this causes ascites, and this disease is common in South America, Africa, and Southeast Asia, as I told you, in warmer climate. What we see in Madurai was a granuloma like this, a solitary granuloma like this. In at least at some point of time, we had nearly 55% of our pediatric uveitis was this granuloma. It was so common. Now it is not that common because we have controlled it. And this is mainly seen along the east coastal area of Tamil Nadu. And wherever this Kaveri river flows in Tamil Nadu, we have this disease. And also in some of the districts of Kerala, Malappuram, and some of the specific districts of Kerala we see, also in Sri Lanka. And this nodule either look like a subconjunctival nodule or anterior chamber granuloma. So we excised these nodules and we collaborated with Dr. Narsingya Rao, a pathologist, world-renowned pathologist, and also a parasitologist. And luckily, to our surprise, this came as a trematode granuloma. And after that, we read a lot of zoology books, and we learned that this is the larva, and this larva, adult worms live in birds, and they lay eggs in the contaminated water here, and first larva come out, and it affects the snails, specifically melanoid tuberculoma snails, and then second larva comes. This is supposed to affect the bird eye, but unfortunately these children take bath without any protection in the contaminated water, and they get the granuloma. And this granuloma can cause blindness in South Indian children. So Cercaria, what we did is we did a wonderful research, and we collected these snails, we collected this Cercaria, we did RT-PCR, and we did real-time PCR also, and we did blast analysis and sequencing, as well as the granulomas from the children. We took this sample as well as environmental sample, and then the blast analysis showed us the result that it is Procervum varium, which is a trematode. And this we published in American Journal of Ophthalmology and American Academy Publication Ophthalmology and Archives of Ophthalmology. Long back, 2002, 1 and 2012. And now we are not giving any, this particular disease was diagnosed as tuberculosis in Tamil Nadu, and a lot of students were receiving anti-tubercular treatment. Now we are not treating with anti-TB. Anybody wants to say anything? Okay. So now I am going to talk about some of the problems in parasitic uveitis. As I told you, diagnosis is a problem. Not every time cysticercosis will be having a beautiful cyst with the scolex. It may present like a very rare presentation, and the serology will not help us. And if we think of management, added neurocysticercosis, as I told you, patient may have, when you start only albendazole, they may have cerebral edema, so which is not safe for the patient. So we have to work with the neurologist and the neuroimaging. If there is no neurocysticercosis, then we can treat with albendazole. And literature, unfortunately, many of the books say white image like America, but unfortunately, this white color is because of lack of literature. Even in Africa, they have literature. Even in Brazil, they have literature. In many of us do not publish parasitic diseases. So the map is white as if we don't have parasite. Literature we have to build. Whenever we see parasitic disease, we have to work on that and publish so that we will know the real picture. When there is no literature, there is no research in developing countries. Unless we prove, unless we publish, there won't be any research. There won't be any good medicine also. So we have to learn a lot in parasitic disease, and this is only outline in parasitic disease. And one most important message to our students: all these worms are accidental. Human play as accidental hosts. So by examining motion test, we will not come to any diagnosis. They are accidental host. So one or two larvae will be in our body, and that will settle in one of the end organs, and it will die, and patient may not have any evidence. Only in the eye, because we have transparent structures, we are seeing them as dancing worms, but motion test will not help us. That is the reason we are not able to prove in many cases. We are not able to take the worm intact. If it is in AC, you put the needle, it will go behind. And you hit with the laser subretinal space, you cannot go and take the worm out. So because we are not able to get the worm, and the motion test will be negative, serology tests are not helping, that is the reason we don't have evidence to publish. But with good photograph and good literature review, we have to publish. I hope you understand. And now, because the time is going up, I'll start with intermediate uveitis.
Oh, can you tell the dose and duration of albendazole treatment?
Yeah,
because
it is.
That is the key for parasitic diseases.
Yeah.
Everyone should know about it.
Yeah, I told in middle of my lecture that it is 400 milligram once a day for 14 days with 20 milligram steroid in every day for a week, 10 milligram steroid every day for a week. Because any worm, when they get killed, they will develop a little uveitis. So patient may become symptomatic after we start the tablet. So we have to give steroid in addition.
Okay.
Yeah.
Ratnam ma'am, one question for the benefit of
Parasitic.
students.
Yeah.
What would be the 5 most clinching signs in a patient when you would suspect a parasitic uveitis?
Yeah, as I told you in the first slide, whenever I have a atypical presentation, which is not fitting with our own known entities, I always include muscular syndrome and parasitic disease in differential diagnosis. Because the Toxocara, which I just mentioned, but I didn't show you the picture. It will be just a white color granuloma in the vitreous, which we may mistake it for retinoblastoma, which we may mistake it for tubercular granuloma or sarcoid granuloma. So anything atypical, we have to have first thing masquerade, and the second thing as parasitic, other than our anatomical diagnosis. Second thing, as in Duchenne, if there is a tract lesion in the fundus, definitely I suspect, and I take them to the fundus camera. I see I take the montage photograph. In the magnified view, I really look for any worm, any small hook-like worm repeatedly. I debut to one student or fellow to search every field. So that is second. Third one is, I had another very interesting patient, right eye preseptal cellulitis, a male patient, 40 years old, and there is no reason for him to have preseptal cellulitis. So just we gave some anti-allergic drug and we asked him to come for follow-up. He came with a second eye preseptal cellulitis with itching. Somehow it was not fitting with anything. Preseptal cellulitis is common in children. So I had an idea whether he has any parasitic disease. I asked the student to dilate the fundus and look for it. And we have recently published that also. That is not presented in this picture. There is a beautiful S-shaped worm in the subretinal space. So unusual allergic reaction, I suspect parasitic lesion. And as I told you, the fourth sign is we will be seeing dancing worms in the anterior segment, and a student will be very much excited, will bring the case to us, and it will not be seen. Then we cannot discharge that patient, telling that nothing is seen. Probably she has seen and it has moved backwards. So we make the patient wait and see again. And the fifth point is, I have to add about ectoparasites. Ectoparasites are parasites that are living in the lid margins. Many of you might have seen Dermatex worm, which has a 8-legged claws and which will be clinking onto the eyelashes. And worm will not be seen at all because it will be in the hair pit, but still it will cause severe itching, and patient will have specifically itching over the lid margin. And if we plug one eyelash and put it in oil immersion microscope and see, we can beautifully demonstrate Dermatex. And that is one sort of ectoparasite. The another sort of ectoparasite is general complaint is itching. And if you see the conjunctival cul-de-sac, you can see Ostrus ovis, which will beautifully move throughout the conjunctiva. And those worms are common in people who have cattle at home. A cattle mouse will have lot of worms, and when it sneezes, it comes to our eyes. Or when they present in the dust, when we sweep the floor in the roadside, we may get Ostrus ovis in our eyes. So whenever patient gives history of itching, don't neglect. See the eye carefully, and if you remove one Ostrus ovis, patient will worship you. So these are 5 signs. Itching is important, and hair follicle Dermatex is important, and track signs are important. And if somebody says some worm I have seen and we don't see, definitely it has gone behind. And sometimes they make iris holes, or they will be hide in the angle of the iris. So these are all the points. Only point here is very, very careful clinical examination. Even for sometimes when 40-year-old lady comes or 60-year-old lady comes, when she says itching, we are likely to send them with some eye drops, Olopet or something like that. No, let us imagine that she has parasitic. Let us search for a parasitic instead of thinking that she may not have anything. Have I answered your question?
Yeah, thank you so much, ma'am.
Can we include iris holes without any history of trauma?
Yes,
With mild
definitely.
uveitis,
Yeah, I have beautiful case. Yeah, I have a beautiful case where I saw 20 iris holes and still the worm was in the eye. So we gave albendazole and we killed the worm. And I used to say that this foolish worm did not see a pupil which is very big. It has not come through the pupil, but it made 20 holes in the iris. I wish I had that photograph here. Yeah. And that is in another presentation.
Thank you, ma'am. I think you really simplified by telling us all those signs, though it's a very complex topic, I know.
Yeah, but it is very interesting. Once you see one parasite, you will be, whole unit will be thrilled. Okay. So now intermediate uveitis is also a gray zone for students. They always have doubt whether to say intermediate uveitis or anterior uveitis, but there are very, very few very important points students should remember either for examination or for their prior practice. I will definitely include those important points. And Sun nomenclature group has given us a very, very clear definition. Vitreous is the major site of inflammation here, and the presence of peripheral vascular sheathing and macular edema will be there. And just because macular edema is there, we cannot call it as pan uveitis. This is a structural damage of this intermediate uveitis. you will be seeing uveitis or inflammatory cell more in this zone, intermediate zone. You may have some spillover inflammation here, and you may have macular edema, but this vitreous will be clear. The more number of intermediate uveitis cases you see, you will not have any doubt. It will be very, very clearly shown that this inflammation is localized here. Predominant localization in the intermediate zone. And this zone is very important because you have ciliary body, you have lens. So the chronic inflammation in the ciliary body can make the ciliary body go into atrophy and detachment, which is a very common, very common complication in children, intermediate uveitis. So once ciliary atrophy happens, I will go for phthisis. And your lens is right in the intermediate zone. So most common complication is cataract. Can we remove the cataract? Unless we control the inflammation, we never touch the cataract. I will show you during the course of the class. And as I told you, sun nomenclature says that intermediate is the inflammatory evidence is seen in vitreous. Vitreous is a avascular structure. It cannot produce inflammation, but all inflammatory cells are loaded in the vitreous. And it is also called pars planatis. Some old literature called posterior cyclitis and hyalitis, but now we are supposed to call this as only as intermediate uveitis. These things are now not in use at all. And what is the difference between intermediate uveitis and pars planatis is most common question we hear from students. See, here you see the snow banking. It is exactly like your white coat. There is a white coat of deposit in the pars plana. Only when you see such white snow banking, you call it as pars planatis. And it will not indicate any disease. It is idiopathic pars planatis. Idiopathic intermediate uveitis with snow banking is pars planatis. You can either have snow bank or snowball formation, which I will show you here. And in India, we have 10 to 17% of the people suffering from in a uveitis clinic, it forms 10 to 20%, and it is seen bilaterally up to 90% of the patients. It occurs both in children as well as in adult. There is no definite gender predilection. When it affects the children, it really bothers them. To control intermediate uveitis in children. And it is extremely important to rule out tuberculosis, because we will be putting these patients on definitely immunosuppressives. Before starting immunosuppressive, we have to rule out tuberculosis. And this often causes band keratopathy and ring synechiae and cataract, white eye uveitis, exactly like juvenile idiopathic arthritis associated uveitis. The only problem here is exactly like JAA associated uveitis, this can also be a asymptomatic disease in children and dense vitreous cells, and patient will not be knowing that they have defective vision. Only on screening examination or accidental examination, we come to know about this in children. And by the time the cataract will be there, ciliary atrophy will be there, and the macular edema will be there, opaque vitreous will be there. It is very difficult. So after ruling out tuberculosis, we have to be really hard in treating. And patients with intermediate uveitis present with minimum symptom, if at all, if they have floaters, they may say floaters, and blurred vision only when vitreous become opaque. In severe cases, they present with vision loss, total vision loss. At that time, it is very difficult to handle. And most of the time, defective vision is because of macular edema. And you know the problem of macular edema in children. I will come to that slide little later. And according to our Nielsen blot classification, they may have zero cells or may have trace cells where you will be seeing even nerve fiber layer. In 1+, you will not see nerve fiber layer. In 2+, even the vessels are seen faintly. In 3+, you will see the disc faintly. In 4+, you will not see anything. So all these things are seen in intermediate uveitis of any age. And snowballs look like this. And most of the time, when you have snowballs like this, it could be because of sarcoid. And when you have retinal granulomas as well as pigmented scars in pars planitis, we have to rule out tuberculosis. Sarcoid never causes pigmentary changes. Tuberculosis always causes pigmentary changes. And tortuosity of vessels and sheathing. This is extremely important. In a case of intermediate uveitis in children, you may be giving immunosuppressive for 4 years, 5 years, and fundus may look absolutely normal and 6/6 vision. You will think that we can stop immunosuppressive. Once you stop immunosuppressive, uveitis will come back immediately with the forcible reaction, and the patient may lose vision. So it is better always we do FFA, and if FFA is not showing vasculitis, it is time to taper immunosuppressive. Even if the patient is on 6 years of immunosuppression, if there is vasculitis, don't stop. Be very, very careful. In fact, FFA should be done every year, whether patient is symptomatic or not. Every year we have to see. We have to take care of these patients till they become 16 or 18 years of age, because vascular occlusion is common and neovascularization is common. Once they have neovascularization, invariably they bleed, then retinal traction and detachment and phthisis. I am not threatening you. Intermediate uveitis in children is a blinding disease. We have to be very careful. And they can develop glaucoma, cataract, macular edema, neovascularization, and vasculitis is the most important one. And BSK in children is a headache. We should not remove BSK unless they become 16 years of age, because once you remove, it will come again. You remove, it come again. Then cornea becomes too thin. So we will live with the patient. We educate the patient that we have to live with the defective vision, but control inflammation and take them to 16 years. Then we will plan for any surgical correction. And as I told you, TB, syphilis, sarcoid, very, very common causes, and idiopathic in 70% of the cases. In these cases, once we rule out TB, we can give immunosuppressive. I have quite a lot of children with intermediate uveitis on either methotrexate or MMF or adalimumab or even cyclophosphamide. People who cannot afford adalimumab, I even give cyclophosphamide. It is very, very difficult to treat, and FFA and OCT are our boon. So if patient can afford, every visit we can do FFA, OCT, and once in a year, definitely we have to do FFA. Intermediate uveitis is a gray zone. We think it is an easy disease. It is a very difficult disease in children. Adult, it is easy to manage. And it is I'll finish now, sir. I am coming to the end. And treatment option is a step ladder pattern. We start with oral steroid, and if the cystoid macular edema is there, we have to go for periocular steroid. And always think about glaucoma in children. And just 2 minutes.
Someone else's this thing. You need not worry. We have time.
Okay.
Don't
Thank
worry.
you. Thank you. Thank you so much.
Syed, can you stop Dr. Meher's audio? There is a lot of disturbances coming from there.
Madam, you continue. Time is not a prayer. Continue,
okay.
Please.
Okay. So oral steroid is extremely important to start with. And if the cystoid macular edema is there, it is not only periocular steroid, but we may need intravitreal steroid or Ozurdex. And by chance, if they have neovascularization, definitely they need Ozurdex. And then comes the immunosuppressive. Immunosuppressive, as I told you, we have to have all immunosuppressive available to us, like azathioprine, methotrexate, MMF, and cyclophosphamide. And some of my children are on adalimumab, wonderful drug. Only thing, extremely expensive. The children who are on adalimumab, they never develop BSK, they never develop cataract, they never develop cyclitic membrane, they never develop ciliary atrophy. And surgical intervention is extremely challenging in these cases. It is better we do surgical intervention only when they become 16 years. But by chance, if a younger child is having totally opaque vitreous, vitrectomy can be done. Vitrectomy with Hemodex can be done. But cataract has to be delayed by 16 years, because once we do cataract, if there is a recurrent inflammation, the cyclitic membrane will get attached to the lens and it will pull down the lens. Invariably, lens get dislocated. And cyclitic membrane will be very dense. When it pulls the ciliary body, it causes ciliary detachment. So some people will always say that anterior vitrectomy and lens, even that is better. Anterior vitrectomy can be done by the retina surgeon, and then anterior segment surgeon will do the cataract surgery, keeping the posterior capsule intact. We do have done some of the cases like that, anterior vitrectomy by a retina surgeon and cataract IOL by the IOL surgeon, because these children will also go for amblyopia. When there is cataract, we may say that we have to delay till 16 years, but by 16 years, if she develops amblyopia, we totally fail. So what I mean to say is, if they have vision, if they can manage, we will control inflammation and delay the surgery. If they don't have vision, we pour down all these immunosuppressive, control the disease, and with real caution, we have to do vitrectomy, cataract removal, and leave the patient aphakic, give aphakia glasses, and make them not to go into amblyopia. Then later date, we can put IOL. So it is left-bladder technique. And nowadays, nobody does cryo or nobody does laser unless they have neovascularization. When they have neovascularization, definitely we do panretinal photocoagulation. So this is about intermediate uveitis. And the steroid, we usually give 1 milligram per kg body weight. Most of the children are 40 kg, adults are 60 kg. Then we slowly taper, and we give only 20 milligram tricot. And if needed, we give more. Intravitreal steroid, either intravitreal steroid, which is preservative free, which comes from Arolab, or Hemodex, depending upon patient's paying capacity. But in vitrectomized eyes, only Hemodex can be given, because your there is no vitreous. This intravitreal triamcinolone acetate will get absorbed immediately. It will not be available for the treatment. So Hemodex is definitely needed. And as I told you already, all immunosuppressives are used in these children. And of course, we have to do blood investigation once in 2 months. And we have very successfully treated intermediate uveitis cases as well, and very poorly treated and gone for Thesical eye, we do have. And especially, I always want to say about one boy, unfortunate Muslim boy, who was on MMF for at least 5 years, and inflammation was under control. He was seeing very well, but for 6 months, there was no recurrence at all. And they were very poor, so they were begging me to stop the drug because they were not able to support the child more than 5 years. I thought, okay, it is more than 6 months, not even single cell. I stopped it, and immediately intermediate uveitis came back, and he became blind in both eyes. And even parents are very, very guilty for asking me to stop. I am extremely guilty that I stopped. So these children behave in a worst way, intermediate uveitis in children. We have to be very, very cautious. And surgical intervention, as I told you, pars plana vitrectomy or cataract surgery. Some of the cases of cyclitic membrane, pars plana membranectomy has been done in some of our cases. It is challenging, but some of the very good surgeons, they handle it so well. They do vitrectomy, they do pars plana membranectomy, they do small hole in the posterior capsule, and then they give the patient to the anterior segment surgeon, who will put the IOL after removing cataract. So it has to be specialized treatment. So this is about intermediate uveitis. I can take up any question.
Thank you very much, madam. It was a wonderful talk as usual. So there was somebody who was asking me the Montauk's test in case of children. How sensitive is it?
Actually, even though we say that they are given BCG, in my experience, many children show negative MANTO also. And when they have negative MANTO, it means two things. One is they are immunologically weak. Even BCG has not mounted any immunological reaction. It is something like anergy in lepromatous leprosy. So these children are more prone for tuberculosis. And another explanation is because we give BCG, unfortunately, on day 1 after birth, the immunological system of the child is not good enough to handle. That is the reason most of the children are still MANTO negative. Textbooks say that Indian children will be always positive. It doesn't happen like that. Many of them negative also. Just because they are negative, we cannot say that they are not having tuberculosis. We have to have extreme thorough checkup for peripheral lymphadenopathy and any scar because of ruptured cold abscess or CT scan and ultrasound abdomen. And even the inguinal node may have tuberculosis sometimes. So thorough examination, systemic examination and radiological examination is needed. MANTO alone is not enough at all. But if MANTO is hyperpositive, more than 15 millimeter in children, it is extremely indicative of tuberculosis.
Ratina ma'am, there is another question for you, that can we find acute signs of anterior segment such as circumcorneal congestion in intermediate uveitis, and whether it is rare or not found?
Very rare, very rare. In sarcoid intermediate uveitis, we can have mutton fat keratic precipitates and circumcorneal congestion. A typical idiopathic intermediate uveitis is white eye uveitis, often.
And ma'am, could you explain a little more regarding this oral steroid therapy, that how do you taper it and when do you add the immunosuppressant in a case of intermediate uveitis, and for how long would you continue immunosuppression?
Yes, first month I give only steroid. And this is to learn about the patient as well as the parents, because invariably parents will be having lot of doubt on us. They always think that we unnecessarily treat their precious children. So when you start immunosuppressive on first visit, they run away from you because we have to counsel them. And when our counselor says the adverse reaction, they run away. And they always blame that the bigger institutes start big medicine and we don't need anything. And eye is white and child is not complaining and we can go to village healer. So what I do is I give low dose steroid and I gain their confidence. I'll tell them that I'm giving very low dose. Let us see what happens. Only when it is needed, I will increase. I know 100% in my mind that I will be increasing. But I will say that only when it is needed, I will increase. So let us first see, and then I show the FFA, normal FFA, as well as the leaking vessels of their child FFA. And I'll tell them the blood vessels are leaking, so you should know the seriousness. And I will also say that we both will have to be in contact and collaboration to save your child till she becomes 16 years. So even in the first visit, I'll make it very clear that this is a serious disease. You have to meet me till she becomes 16 or 18, but I will give low dose steroids and they will come with the same symptom. Nothing would have happened because you are giving after all 20 milligram. Then I know that they are committed to me, they will come. Then I increase the dose according to weight, body weight. And I tell them second most important thing is Cushing guide. Definitely, unfortunately, I always use Jayalalitha as my example because Tamil Nadu people love her. So I'll tell her, even our Jayalalitha had steroid side effects. So, and I had steroid dose many times. So I used to say, I was taking steroid. I was also very much stout. We don't bother about being stout, but we are worried about vision. Then I give full course of steroid. Then they come to me. Only when they come to me again, I know that they have confidence in me. Then I start immunosuppressive. I tell them we have to avoid steroids because your child is putting on weight. So I will go to steroid sparing drug. Then they will know, okay, we are going one step after another. Then third visit, I start immunosuppressive definitely.
And for how long, ma'am?
It's more than 5 years, 6 years, depending upon the inflammation. And absolutely, when there is no vascular leakage for 1 year, I stop.
So which is your favorite
Methotrexate, because we have quite a lot of experience. The Western world had used the tablet for more than 40 years. And if at all, if the child has liver function problem, then I go for azathioprine. But I really don't like azathioprine because it is very weak. Methotrexate, then I go for MMF. Some patients are on methotrexate and MMF. When we add these two in lower dose, we can add methotrexate 15 milligram and MMF according to the body weight, either 250 milligram BD or 500 BD, because MMF acts only for 12 hours. So if you treat with MMF, it has to be BD dose. So we have to tell the patient that it will exactly work for 12 hours. Then they understand and they cooperate with us. With the double dose and steroid, most of the time the inflammation will come under control. And with maybe we may need Avastin, we may need intravitreal steroid, we may need periocular steroid, all those things in between whenever there is a flare-up.
And
one more question. Yeah, sure.
I'll just ask one small thing, that in a child, would you always start with subcutaneous methotrexate, or you?
Yeah, subcutaneous is very, very good because bioavailability is good. But the only thing, if they are from village, they have to search for a doctor for subcutaneous. If they are educated, I teach them, because I teach them in my own clinic how I inject, and they just pick up that. If they don't have any support, unfortunately, we have to rely on tablets. And the only side effect in methotrexate, 1 in 10 patients out of 100, 10% of the patients will have extreme fatigue on the day they take the tablet. Extreme fatigue in the sense they cannot get up from the bed. So I tell them 10% of them can have this side effect, but take the tablet at Saturday night, whole Sunday you take rest, and Monday you will be back to home, back to work. So that is very small number of patients, but it do occur definitely.
Madam, in those cases where there is a spillover anterior uveitis, how do you differentiate that from intermediate uveitis?
See, the amount of inflammation will be more in the behind the lens than in the anterior segment. But when they are on topical steroid, sometimes it will definitely confuse us. But nowadays, people, even drug trial people agree that intermediate uveitis can have anterior segment component, which is significantly active. So only thing is you have to add topical steroid. If there is no anterior segment inflammation, no topical steroid, because we don't want to make the patient glaucomatous. But if the patient has spillover, you see that you are giving homide always. Even if there is no posterior synic A, on Saturday they can apply 1 drop homide. So they will not have any synic A. They will have active mobile people. Once in a week is enough.
Ma'am, can you ask some posterior students what they've understood till now?
Yeah.
I think we should ask the students.
Yes, sir. Yes, sir.
Excuse me, ma'am. And one question. Right now, you said we should start with homide. Ma'am, what is your choice of cycloplegic? Should it be atropine or homatropine?
Homide. At least theoretically, people say that cyclophosphamide can cause chemical iritis. I don't have experience, but because books mention like that, I always use homide. I never use atropine in children because it will cause fully dilated people and synic A in fully dilated situation. That is very, very, very cumbersome. Then they cannot see the light at all. So I always use homemade. And atropine I use only in my OPD, only for HLA-B27 uveitis. I apply once, that's all. I never prescribe.
Thank you, ma'am.
Any other questions from the PG students?
And for the benefit of the students, can you tell what are the side effects of each of these medications that they are going to use, and what are the blood tests that they should regularly be doing if they're using?
Yeah, in methotrexate is a liver toxic. So all these immunosuppressive, TCDC, hemoglobin, platelet count is a must, because any of them can cause aplastic anemia. So TCDC, hemoglobin, platelet count is extremely important in every immunosuppressive. Whereas in methotrexate, in addition, liver function test. And MMF usually very, very safe, but again, at least once in 4 months, we have to have liver function test. In case of azathioprine, thrombocytopenia is very common. So TCDC, platelet count, hemoglobin, that is very important. Liver is usually not affected in azathioprine. Methotrexate and MMF liver function test. And in cyclophosphamide, aplastic anemia is very, very common. And always check urine for RBCs, because they can have hemorrhagic cystitis. But usually cyclophosphamide I give only for 6 months. Within 6 months, uveitis will come absolutely under control. Even though it is a very toxic drug, it is a wonderful drug.
Dr. Pragati, you want to ask something? Yeah, unmute yourself. Unmute yourself.
Yes, sir.
Yeah.
So, I basically wanted to ask how, when do we start tapering the dose of steroid? In the first visit, you said that in the first visit you start a low dose steroid, then till second visit you increase the dosage, and then third you start the immunosuppressants. So tapering the steroids would begin after we've added the
only after inflammatory control. I taper. At least I keep them on 10 milligram every day for 1 month, then 10 milligram on alternate day for a few more months. Then when nothing happens, when there is no uveitis at all, I make it 7.5 milligram alternate day, 5 milligram alternate day, 2.5 milligram alternate day, and I keep them on 2.5 milligram alternate day forever till I stop immunosuppressive. And even today, one patient on 2.5 milligram, on 2 days a week I was giving. He was a VKH patient on methotrexate and adalimumab. 90 injection has been given, and everything was absolutely under control. He is coming to me for past 2.5 years, 3 years. Before COVID he came, and now I wanted to stop the 2.5 milligram, which is given just 2 days a week. He has recurrence. So the 2.5 milligrams steroid was holding everything. Unfortunately, now again I have started steroids in that patient. So 2.5 I never stop.
Thank you, ma'am.
So when you are starting the immunosuppressants, ma'am, in a patient where you have started initially steroids, what dose of steroid would you add immunosuppression, or would it be that once you've completely come to a level less than 10 mg would be when you're going to be adding immunosuppression?
No, not at all, because all this methotrexate, azuran, as well as MMF take at least 1 to 2 months to really act. So when they are on 40 milligram, I start immunosuppressive. By the time you taper, these tablets will take over. So I don't wait for steroid to come down and then start this.
I think that's something very important for the uveitis patients.
Yeah.
Excuse me, ma'am. Ma'am, what will be your take on a necrotic mantle without any other evidence of TB? Like nothing on.
Yeah, if it is necrotic mantle, I am very, very careful if I had to start immunosuppressive. There will be a situation everything will be under control with steroid, and when you taper steroid, it comes back again. It can be very well TB or it can be very well autoimmune. My question is, why don't you think of ATT trial rather than think of immunosuppressive? ATT trial, within 2 months, you will know the result. And by chance, we miss a case of tuberculosis and give immunosuppressive. And if the child become miliary tuberculosis, then we cannot forgive ourselves. So necrotic mantle, definitely I give ATT trial rather than immunosuppressive.
So, ma'am, you're suggesting that with the necrotic mantle, ATT trial is a good option to begin with.
Yes, definitely, definitely. Because see, you may have, I have tubercular epididymitis, tubercular salpingitis, real cases, tubercular mesenteric lymphadenitis, para-aortic lymphadenitis, omental tuberculosis, peritoneal tuberculosis, pericardial tuberculosis, pleurisy, and intracranial tuberculosis, and tubercular sinusitis, tubercular lacrimal gland. So, and tubercular osteoarthritis of a particular bone, biopsy proven. Whatever I say is, all these things are biopsy proven. Because we have nearly 80,000 cases in this 30 years, I have quite a lot of tuberculosis cases with the extra pulmonary tuberculosis. Our screening system cannot screen every place of the body.
Ma'am, I had a doubt. How confidently can we rule out tuberculosis with a Mantoux test? If it's coming out to be negative, how confident can we?
Never. It is only the clinical picture and ocular picture. Mantoux is only a supportive evidence. And by chance, if Mantoux is negative and patient may have even pulmonary cavity. I have a patient with the bilateral pulmonary cavity with negative Mantoux. That's what I was telling. He is allergic to Mycobacterium tubercular antigen, and he developed a very severe form of tuberculosis. And so Mantoux can, you can only explain the Mantoux, why it is negative, why it is positive, but it is a very tricky test.
So, ma'am, whenever working up such patients of uveitis, we definitely need to rule this particular tuberculosis out. So just having a negative Mantoux is sufficient, or should we, based upon our clinical judgment, should we?
Clinical judgment and your CT scan. I know CT scan is harmful than X-ray, but I think making a patient biliary tuberculosis is more harmful.
Dr. Sharmishta, would you like to have some comments?
Yes, sir. In our institute also, it is up to the clinician to decide when to start the ATT. We come across a number of cases, and like ma'am said, we try with ATT, and then if it's not responding, we switch over to usually we use methotrexate. Folitras 15 milligram once weekly is what is given.
Right.
For the adults.
Absolutely right.
And along with it, we give folic acid 5 milligram, except on the day when the methotrexate is given. And that is to continue for 6 months or so.
You can safely give till 2 years, no problem.
Yes.
Only cyclophosphamide has to be reduced by 6 months. All other immunosuppressive, you are safe for 2 years.
2 years. And yes, ma'am, we also do LFT intermittently.
Which one?
LFT.
LFT definitely once in 2 months or 3 months.
Okay, I think now it's time to end up.
Yeah.
Okay. So you have really extended this. Before I offer the vote of thanks, I request our host today, the webinar hosts, or entered people to share their video for 1 minute. Then I will conclude. Mr. Syed, do you have the video?
Yes, sir, I'm sharing.
Please. Thank you, madam. Really, it's wonderful discussion, and you made it very simple. We have never seen these worms in our life. Probably we have seen a lot of nematodes, lot of cystors, and everything. Really, thanks. Out of your busy schedule and out of so many problems, you could come and join with us and enlighten us. Thank you.
Thank you so much, sir. Thank you, Babu, also for making it possible.
He's behind this. He's behind, without him.
Babu took so much effort, and I thank Babu because I really enjoyed interacting with students.
And we were not sure till yesterday morning that you will be joining with us today.
Yeah, the problem was we are 5 medical officers. They say that you are always talking. No, you are not allowing anybody to talk. I told, no, Dr. Babu invited me. Like.
So thank you, ma'am. Thank you, ma'am, for coming to our webinar, ORTS webinar. And of course, today really we are fortunate to have Dr. Manisha Agrawal. She has interacted really very well. Excellent, madam. And we have done wonderful moderating the session today along with our own Dr. Sanghamitra Kanungo. And panelist Dr. Tripti, I think you were very brief today, but I wanted to have you more discussion in the participate in the discussion today's webinar. Anyhow, we will be looking forward to meet you again once again in our future webinars. So thank you very much for joining with us. Our other panelists, Dr. Sarmishta Behra and Dr. Sachala Bhoi, is joining with us. Thank you. And all students, really, but still we want that more from you. You are sitting silently. Please come forward. Dr. Priyambada, Dr. Pragati, Dr. Pratibha, your case was really wonderful case presentation today. You have done very well. And Dr. Sabya was sitting idle only, sitting quiet. So you people, this is your program. You have to come forward and interact with the experts. So thank you. And last but not least, our mentor, Dr. Ajit Babu, really correlating all the webinars since last 4 sessions. So thank you very much, sir. And our president, Dr. R.C. Meher, sir, thank you very much for joining with us and introducing the webinar to all the EIZOC people. So on behalf of the scientific committee, I thank you very much for staying with us, and all the viewers, including our president, Dr. Jairuddin Khan, is also with us. So thank you all for joining today's evening program, and we look forward to join with us in our next programs, ORTS 5 and also ORP 4. Thank you, entered people supporting the webinar today. Thank you very much. Thank you all. Good night.
Good night,
Thank you. Thank you so much.
Thank you, sir.
Yes, sir.
Ratnam,